So I'll take up the first topic, which is the choice of presbyopic IOLs in current scenario.
Dr. Parul is a very prolific cataract and refractive surgeon. She's head of department at Max Hospital, Gurgaon.
So I think more and more cataract surgeons now are aiming to make their patients less dependent on spectacles most of the time. So it's not an overstatement when we say that currently cataract surgery is perhaps the most common refractive surgery now. And we've seen the evolution in all the presbyopic lenses where we started from a simple refractive bifocal to where we have come now, and even most of the lenses have toric incorporate in them now. So despite the evolution of presbyopic glasses, our patient will still have those little problems which make us deter and be wary of the presbyopic lenses. And that is the aim, to give you the choices where you do not end up spending so much time, energy, and your patient is spending that cost and still saying that it's not so good, doctor. So what are the choices? There are quite a few choices out there. And how do you select which kind of presbyopic lens would work best for your patient is what we are going to take up. But before that, in choices of IOL, we've come a long way since we started with refractive multifocal, where the limitation was that they were pupil dependent, they were sensitive to centration, would cause a lot of decrease in the contrast sensitivities and halos and bursts. So we move on practically from this stage to the diffractive multifocals, which are less pupil dependent, not so sensitive to centration, and the amount of halos and glares has also become much less with the finesse and the technology which the lenses have adapted now. The other, the spectrum is the EDOF lenses, which are very popular now. They are based on either inducing a spherical aberration in the center or having a raised platform or a wavefront technology. You also have the extended range of vision, where again the idea is to stretch the wavefront, which shifts the light to give an extended focal length and hence a continuous range of vision. Then is a category where they're doing a sandwich, a mixture of both diffractive and EDOF kind of lenses. So you have diffractive hybrid IOL, or you have a diffractive refractive multifocal hybrid. Again, all the modifications to improve the performances of these presbyopic lenses. So to touch upon the modern ones and the ones available in the market which we are using, this is a very favorite lens of a lot of people, a PanOptics based on the diffractive trifocal technology. Again, a similar concept by Zeiss. Then you have the wavefront one, the VVT one, that's been on the extended range of vision, which I said is the wavefront stretched thing. Minivel is a progressive EDOF lens, where the positive spherical aberrations in the central 3 millimeter zone create that kind of multifocality. Synergy is a hybrid between a refractive and a diffractive lens. Here they have combined the posterior diffractive multifocal with multiple rings and a central EDOF zone. They've also added an achromatic technology, and the company claims that we have a better resolution edgelet. And with advanced lathing of these diffractive rings, the total amount of scatter and the total amount of glare and halos is less. Another example of a hybrid refractive lens is the Lucidis, pretty much based on the same principle. And another lens not to leave behind our Indian companies is Suprafob in focus by Appa. It has a small central zone for near vision, a plus 3.5 mid peripheral, and an intermediate. Claims to be less independent on dependent on the pupil. So a lot of people till now were confident about only the imported lenses, but recently the India market has become very hot, and in peripheral centers or your patients who cannot afford very that kind of cost bracket, these are good lenses. I've personally just use Supra 4 and Magnifend, not much experience. So we look forward to the other speakers sharing their experience, but they are turning out to be good one. IOCare Naturopan Focal is to be launched soon, and this one claims to be giving a much better contrast in distance vision, and also much less halos and glare. So let's see where this all takes us. Not to forget one bracket where you're transitioning. This is a safe lens, which is like an enhanced monofocal. So it gives you both distance and intermediate. No downside to it except for doesn't work in astigmatism of more than 0.5, 0.75. So if you are transitioning from monofocal to multifocal, this is probably safe bet. So after this overview of all the presbyopic lenses, Basically, the question is what your patient wants. All patients would want, dependence from glasses most of the time. One thing which has changed in the post COVID, or the, let's say, from past few years, is the digital shift. So earlier, how with bifocal we used to only focus on distance and near. Now it is a continuous range of vision where the intermediate tasks have also become very important. So how do we choose the lens, right? uh, we talk to the patient, because it's not about fitting any lens in any patient. You understand their visual needs. It also gives you chair time to talk to your patient and understand and build up that rapport with the patient. Choose a established predictive outcome. So for example, if I've shown so many lenses and they've not been tried and tested, you don't want to burn your fingers by trying anything new. So rely on the colleagues who have used these lenses, take a feedback from them as to how their experience was, and then start your practice on that particular lens. How do you select the profile? Is select patients who are self-motivated. You don't want to waste too much time in pushing the patient to have a presbyopic lens and then have a patient who's not so happy with the results. If he's an avid night driver, I'm talking about initial selection. Later, of course, it doesn't matter because you have EDOF and other choices, but you would, want to keep this kind of patients for your later practice. Better to do bilateral implants, because then the outcome and the neural adaptation is much faster. Clinically, make sure that they have no ocular surface disease. Make sure that you treat the dry eyes before you do the presbyopic lenses. Corneal topography is very important to rule out any kind of irregular astigmatism, because that affects your visual outcome. See the astigmatism very carefully, and our speakers will talk about planning of that also. And initially avoid post-refractive patients because of their irregular corneas and problems in calculating, which we will also touch upon. So patients to be avoided. Somebody who's very happy to wear glasses, why push him not to wear glasses? That's okay. Very aggressive type A kind of people, or people who have mental health issues, who are on medication, bipolar, schizophrenic, you would want to avoid these lenses for them. As I said, very avid night drivers in the initial part of your practice, irregular corneas, severe ocular surface diseases, and macular pathologies, you do need to do your OCTs to find out any fine ERMs or drusen's which could affect the post-operative outcome, and also post-refractive eyes in the initial part of your practice. Based on ocular condition, as this is a repeat of what I said, pseudo exfoliation, zonular laxity, you would be wary of doing presbyopic IOLs initially, because the centration is very important. Diabetics patients can be taken up for presbyopic IOL if they are well controlled. It's not a contraindication. Similarly, early glaucomas are not a contraindication. Fine ERMs, very few drusen's which are familial, non-progressive, again can be taken up for presbyopic. Low threshold initially, keep patients who don't have that much astigmatism. Only once you're comfortable with presbyopic IOLs, go on to toric presbyopic IOLs. So choose your patients, and you can manipulate your biometries on a toric planner and take incision on the steep axis for small astigmatism, or keep them for later LRIs. Can you take up one eye cataract, one eye monofocal lens done, and the other eye patient wants a multifocal lens? Yes, I've done a few patients. You have to explain them about neural adaptation, but it won't be a perfect situation, but they won't be looking around for their reading glasses for everything. So you can do a mix and match if your patient is ready to adapt, and be okay to have top-up glasses as and when required. So this is very important, as I said, to talk to the patient to understand what their occupation is, how much distance they need, what intermediate work they are doing, how much reading they are doing in the night, how much night driving they have, and if they are open to having used glasses for any small refractive residual error. So if you have that kind of discussion with your patient in detail, then post-operative patients, you won't have them so unhappy, or they are already mentally prepared. Also see their cost affordability. As I said, don't push them, but don't even judge the patients, because sometimes you just look at the patient and you feel that, oh, probably he's not the presbyopic IOL or the premium IOL kind, and you don't offer them. And later patient feels very cheated, and his neighbor will not be wearing glasses, and he says, doc, you haven't given me that option. So we give that option to everybody. We have a ready format of all kind of lenses, and once they show their interest, then we have a detailed discussion. So I'll just summarize by giving a broad comparison between diffractive and the EDOF lenses. Which one would you want to choose on? So if your patient wants a crisp, good distance vision and excellent near vision, the diffractive IOLs, the patient is able to hold objects pretty close also, and in good lights they do extremely well. I would choose a diffractive lens. If you're doing too much night driving and young patients, then I would choose an EDO if not so much diffractive. Again, if the patient has type A personality or other mental health issues, probably my go-to would be an EDO of lens because that's more forgiving, and I would not do a diffractive lens. So for beginners, the EDOF is more forgiving. It has less halos and glare, but the only challenge with EDOF is that sometimes you may need a top-up glass for very fine reading or patients who are used to holding very close objects. So it gives excellent distance vision. Intermediate is very good, but for very fine, you may need top-up glasses. You can also do a micro monovision because that's what we do in our EDOFs and VVT. So one, we aim as close to zero as possible emmetropia. Another, you can keep the next myopic on your biometry like a minus 0.25 or a 0.3. So that is a broad comparison in choosing the type of presbyopic lenses. The last slide is on what kind of cases to choose if you're starting your presbyopic practice. Is hypero presbyopes. They are the most happy with whatever they get, minimal astigmatism. Again, decide on the visual needs. I've given you an idea of how to choose, preferably bilateral, because the neural adaptation is much faster and they are happier that way. And as I said, you can, if there is a small residual error, your biometry is a little off, you can do a micro monovision correction in the other eye, or plan whichever way to balance out the other eye also. And do not burn your fingers by missing out something on the OCT or something on the corneal topography. You may have chosen the best of lens, done the best of surgery, but you will have an unhappy 6/6 N6 because you've missed out a comorbidity. So with that, I will invite the other speakers. The presbyopic IOLs are still, work in progress. So they'll keep getting better and better. It's a journey, but we just have to be careful about how we plan things. So you're saying if there is anything residual and you want to do LASIK on top of it, you can, and we will do. Suppose it's very off, because usually when you are planning premium IOL and multifocality, there's not a much of a gap. It's a very small residual error, and you always have two eyes to play with. So usually we try and compensate it with the other eye as and when possible. Give spectacles meanwhile. Only for a very gross thing would you want to do a LASIK. So touch wood, I haven't felt the need, but yes, it can be done if there's been a calculation error or something very gross, or if somebody's patient has come later. And those are smooth transition profiles. So the way we choose a presbyopic lens on a multifocal platform, so you go to using your true Barrett formula and look at your EKR holiday. So here it's a reverse calculation, but probably that's the only way forward if the patient doesn't want to wear glasses. Yeah.
No, I think you need to include it as part of a possibility, because see, you have promised them something. Yes. But you can tell them, I don't know how many would, unless you have your own LASIK facility and you're doing a PRK or, which is really not costing you much. But if you have to take your patient to another facility, you have to tell the patient that there may be a surprise. And I think, with our the kind of biometry we do today with our optical biometers and using the latest generation formulas, refractive surprises are quite rare. But if the patient has had a previous refractive surgery, or if you're choosing a patient of an RK, which normally you would not put such lenses in them, but those are the rarer cases where you would have a refractive surprise.
So if it's your own patient and you have picked it up early, say in the first week or the first 2 weeks, and and you found out that it's a refractive surprise, if it's up to 1.5, you can probably wait and then do a touch-up, laser touch-up. If it's more than that and you have proven it yourself, then it would be probably better to do an IOL exchange. If it's somebody who has come from referred or come to you for a second opinion and maybe a few months already beyond the first surgery, then there's no question of IOL exchange because fibrosis is already set in. And then probably you can think of, but you cannot do it for a very high